Thank you. So my talk today is on the effects of exercise on benign prostatic hyperplasia. A brief outline of the talk. So we'll start off by defining the problem, talking a little bit about the background on BPH, and then we'll move on to studies examining the effect of exercise on BPH, moving on to some postulated potential mechanisms of effect, and finally concluding with recommendations for our patients. So why are we interested in BPH? Well, here's some data from the US. The prevalence of BPH in men aged 60 to 69 is approximately 70%, so a large percentage of our population and of our patients will be affected by this, this condition. In the year 2000, over 4.4 million office visits and about 100,000 emergency room visits were due to BPH. The annual cost approaching approximately $10 billion, so a lot of money. Definition of BPH, originally a histologic diagnosis. This was well characterized by McNeil in 1968. Relationship between BPH is not always simplistic in terms of its presentation. So as urologists, we treat the symptoms, so lower urinary tract symptoms, or LUTS, don't always correspond well. The degree of bladder outlet obstruction can be asymptomatic in large prostates. Conversely, it can be very severe with small prostates. So as part of the tools that we have to sort out the symptoms, the AUA questionnaire, or the IPSS validated questionnaire, is a series of 7 questions and a bother score, which allows us to determine how severe the symptoms actually are. However, the severity of the lower urinary tract symptoms and the correlation to BPH is still difficult to sort out due to other factors that may contribute to LUTS. These include local factors, hormonal changes, aging, ischemia, other concomitant diseases, and neurologic diseases. This is a graphic representation of the same point. So this is taking men in total. Of these men, in the green, we see that majority of them have histologic BPH. However, of these people that have histologic BPH, whether they actually have enlargement of the prostate, there's another subset of patients. Whether they have actual clinical symptoms is another subset, and whether they have bladder outlet obstruction is yet another subset of these patients. I'm not going to spend very much time on the anatomy. We know that the prostate's in between the bladder and the urethra, and the phallus. So cross-sectional pathology demonstrates that most of the tissue responsible for BPH located here in the lateral lobes consists of nodules of tissue, which McNeil described to increase in size and number as we age. This is a cystoscopic view of the same. And moving on to possible treatments. So we know that once there is a diagnosis of BPH, treatment can involve modification of factors such as drugs, fluid intake, lifestyle advice, which is what we're going to be focusing on today. Failing that, drug treatments may be recommended, and specialized management, which essentially is surgery for the prostate. Well, we know that BPH is associated with age. It's thought to be associated with sex steroid hormones. Age is not really modifiable. The hormones we modify through the use of medications such as 5-alpha reductase inhibitors. However, other risk factors do include, for decreased risk, exercise, moderate alcohol intake, and veggies, and increased risk, obesity, diabetes, and a meat and fat diet. So those are things that we can modify and suggest to our patients. So in looking at the studies that examined the effect between exercise and BPH, there were a few major studies. These are all cohort studies. The Health Professionals Follow-Up Study, performed in 1986 through Harvard, was a prospective study looking at heart disease and cancer. We're familiar with the PCPT. So these investigators looked at the placebo arm of that study. Another major study would be the Massachusetts Male Aging Study, which was performed in 1987. We started off with a paper. This came out in 1998 with Dr. Platz. They looked at the HPFS, which of all the studies had the most patients, approximately 50,000 males. These included professionals in dentistry, veterinary medicine, pharmacists, optometrists, and podiatrists. There was a complementary study examining nurses for female health, and questionnaires were mailed out every 2 years. Of these 50,000 patients, 30,000 were suitable for this study. They defined BPH fairly broadly. This was determined by either surgery or the requirement of surgery, symptoms, so the AUA or IPSS questionnaire, or a positive digital rectal examination. Of their 30,000 individuals, about 4,000 had BPH. Exercise was assessed differently within each of these studies, so we'll just mention that within this study, they looked at the amount of exercise that an individual performed during the past year and attempted to divide it up into amount of exercise per week. This was then converted into MET hours per week. And a MET, for those who don't know the definition, is kilocalories per kilogram per hour during rest, so pretty much sitting quietly. The patients were then stratified into quintiles according to their level of physical activity. And this is some of the data. The red arrow shows that benign prostatic hyperplasia decreased as we go from the least physically active quintile to the most actively physical quintile. They also controlled for a number of other variables, including age, race, smoking, alcohol, BMI, waist circumference, and these are listed in this table as well. Further breakdown of BPH into total cases of BPH, surgery, and the symptoms, so high to severe obstructive symptoms. And as we see over on the right-hand side, these were all significant, and they had an inverse trend as the amount of exercise increased. Their conclusions: highest to lowest quintile of exercise had roughly an odds ratio of 0.75. for probability of requiring surgery for BPH. They concluded that increased physical activity was beneficial for limiting the symptoms of BPH at any age. We move on to a second study by Meigs. And this was performed examining the MMAS. This was performed out of the Boston region. A lot less men in this study, so approximately 1,700 men, followed around the same era, so 1987 to 1997, approximately 10 years, and also assessed with questionnaires. Their definition of exercise differed, so they categorized their patients into moderate, vigorous, or heavy based on the kilojoules that they were exercising. BPH was similar in definition, either symptoms, a diagnosis by physician, or requirement for surgery. What they found, risk increases with age. That's not surprising. So as we divide up the patients into age ranges, we see that the prevalence of BPH does increase. What did they show in terms of relation to physical activity? Well, comparing the most active group of patients to the least, there's an odds ratio of 0.5. They concluded that physical activity was protective over the course of the 9 years that they studied their patients. This was roughly a 0.5 decrease. This is an interesting study which looked at 28,000 runners and compared the running distances as well as their performance in 10-kilometer marathons to the risk of BPH. They also defined BPH, whether a physician had diagnosed or actually they didn't have the same criteria. So this differs from the previous two studies in terms of BPH definition. There was no IPSS, no digital rectal examination. What they showed was a dose effect. So the patients that ran the least per week had the highest prevalence of BPH, and this decreased as we increased the amount of exercise. The most effect was seen at 33%. This was also seen in 10-kilometer marathon performance. So those who ran the slowest, so less than 3 meters per second, had a higher prevalence of BPH compared to those who ran the fastest. What's interesting is that there was a dose effect, and the dose effect was higher than the levels of exercise recommended by large institutes in the US, so American College of Sports Medicine, the Heart Association, and the Center for Disease Control. This decrease was approximately 32%. There were negative studies that didn't show any effect between exercise and BPH. I think the most significant of these was one that was performed by Kristal. He looked at the placebo arm of PCPT. I'm not going to go into too much of the details of PCPT, but it was originally looking at chemoprevention for prostate cancer, as we should all know. Physical activity in this study was assessed by a six-item questionnaire. I couldn't find the description of how they broke up the questionnaire. The incident of BPH was also defined differently. So instead of a positive digital rectal examination, prevalence of BPH in the population, they just defined it as incidence of BPH during the study. So patients had to develop BPH during the 7 years. They also excluded physician-diagnosed BPH, which was different than the previous studies. They found no correlation. These were the risks. So I have a summary slide of the available literature. I'm not going to go through all these studies, but I think we've touched on the major studies. The ones that we've touched on up here, Platz, William Meigs, were some of the largest studies, and these were the prospective studies. There's a number of case control studies, which I'm not going to talk about, and these were negative studies. So we talked about the Kristal study and the PCPT placebo arm. Overall, when you look at the range of literature, there's a relative risk between 0.5 to 0.75 in terms of relative risk, and then these ones have no association. There was a meta-analysis that combined all this available data. The group by Parsons searched Medline. They took 8 studies in total, combining 43,000 men. Since the definitions of exercise were different between all the different studies, they chose to stratify into light, moderate, and vigorous groups based on their own definition. As noted, the previous study had different number of activities versus hours per week, and then different measures of energy output, so it was difficult to compare directly. The definitions of BPH also differed between the studies, whether they looked at purely BPH or LUTS. So Parsons combined them and looked at either BPH or LUTS as a endpoint. These are the studies that they examined. There's a lot of overlap with the previous table. And what they found was that odds ratio was approximately 0.7 between light activity, moderate, and vigorous. However, only the moderate and vigorous activity levels were significant. What they concluded was there was approximately 25% benefit of moderate or vigorous physical activity over sedentary patients for reducing the risk of BPH or LUTS. Their problems stated in the study were heterogeneity, differing definitions, and differing techniques in terms of analyzing patients. So we're switching gears a little bit here now. We're going to talk a little bit about the postulated mechanisms of action. The mechanism is still unknown, but it's thought that androgens are required to allow BPH to occur. We know this through a number of observations. Patients that have 5-alpha reductase deficiencies, we know that castrated individuals, whether it be by orchiectomy or a chemical castration, have reduced prostate size, and the castrati do not develop difficulties with BPH. So a number of postulated mechanisms are available. These are mostly based on the idea that exercise is linked to risk of metabolic syndrome, and the decrease in metabolic syndrome thus exerts effects that reduce the risk of BPH. Some of these mechanisms are decreased sympathetic nervous system tone, effect of IGF on hyperplasia, effect of inflammation on hyperplasia, and exertion through steroid metabolism. This is a visual representation of the same. So sympathetic activity can increase the dynamic component of BPH, whereas a number of factors that increase the hyperplasia or prostate growth can also increase the rate of BPH. This is an interesting study by Tom Louie's group out of UC San Francisco. He was looking actually at erectile dysfunction, but they fed rats high-fat diet, and we see the groups of rats here. So the total cholesterol and the prostate weight was significantly different in their high-fat diet rats. We have a histologic slide here showing a cross-section of a rat prostate, and in the brown is the smooth muscle that that was stained, and we note that in the normal mice, the rim of smooth muscle is fairly minimal compared to the enlarged or hypertrophic smooth muscle in the high-fat rat. So I'm just showing that high-fat diet may cause hyperplasia in the prostate. This is a slide I took from my talk last year. We know that testosterone decreases with age. So age on the bottom, level of testosterone in green. Overall testosterone decreases as well as free testosterone. This goes back to examining the relationship between testosterone and BPH. There haven't been completely clear studies demonstrating, or the literature in the past is not all in congruency in terms of testosterone and risk of BPH. So one of the postulated mechanisms is that estrogen and the ratio of estrogen to testosterone may have an effect on BPH. We know that estrogen metabolism is closely linked to testosterone. It can be converted from testosterone to estrogen through aromatase. This in turn is affected by obesity and the level or the overall amount of adipose tissue in a patient. And what we do know is that estrogen receptors are present on prostate cells. Estrogen receptor alpha and estrogen receptor beta have been linked to apoptosis as well as cell proliferation. Another mechanism by which hyperplasia may occur, IGF. Insulin growth factor is a receptor that cross-reacts with insulin. We know that insulin levels may be increased in patient populations or in patients that are obese or have metabolic syndrome. This increase in insulin can therefore cross-react with IGF, and the IGF can cause a cascade of events, possibly causing hyperplasia in the prostate. This group out of Japan in 2007 created a transgenic mice overexpressing IGF in the prostate, and their results were that transgenic mice, and this is just one example in one lobe of the prostate, transgenic mice had larger prostates than non-transgenic mice. A knockout model of the same showed the opposite effect, so a smaller prostate in a knockout IGF mouse. I'm not going to dwell too much on this slide. It's just to illustrate that the interactions between metabolic syndrome and obesity and hypertension or increased sympathetic tone can be very complex. A number of cytokines can be involved, inflammation through fatty acids. There's implication of the hypothalamus as well as levels of intracellular calcium. One study did look more closely at leptin and the secretion of norepinephrine. This is to suggest that overall sympathetic tone is increased in patients who are overweight or obese. So switching gears again, what do we tell our patients? Well, we know that, and this is Canadian data, in terms of mortality, heart disease is still, if not the prime contributor of mortality, it's up there, and compared to the other conditions that urologists treat, heart disease is going to affect and kill off more of our patients than anything else. We know that exercise has a number of benefits: cardiovascular disease, hypertension, stroke, diabetes, osteoporosis, lipids, erectile dysfunction. And this has been discussed in previous grand rounds. There's a push for urologists to advocate for men's health. This paper mentioned 10 different suggestions that a urologist can provide to their patients. Number one on their list was actually exercise. So, besides promoting better eating, better work-life balance, preventing, screening for colon cancer, improving lipid profiles, exercise was one of the number one recommendations. The American Heart Association, as well as the American College of Sports Medicine, have put forth guidelines. This states that activity that's recommended includes moderate activity for 30 minutes, at least 5 times per week, or vigorous activity at least 3 times per week. Strength training does help. It works through different mechanisms, and patients may benefit from increased level of training over the minimum suggested levels. So what we can conclude is that there is a large amount of observational data suggesting that exercise is beneficial for decreasing the risk of BPH. This decrease in risk has been observed to be between 25 to 50%. We can note that there has been no randomized controlled trials. The benefits demonstrated by a few of the studies appear to be dose-dependent, and there's question of whether there's any upper limit in terms of what may be beneficial. So at the very least, I think we can say that patients should be exercising at the minimal guidelines, and anything above may help. Finally, there is little downside to the promotion of healthy living. And acknowledgements to Dr. Ken Poon for reviewing the slides.